At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome. I'm Donna Cryer, the CEO of the Global Liver Institute, and I have the honor of being your host for GLI Live. We are doing an incredible series for both Minority Health Month and Donate Life Month. I am incredibly blessed to be at the intersection of both as a 27-year and counting liver transplant recipient. And so I cannot think of a better guest to help us explore the issues here at the intersection than Dr. Darrell Gray II, who is a founding board member of the Association of Black Gastroenterologists and Hepatologists. Dr. Gray, hello.
Thank you so much for having me, Donna. It's truly a pleasure.
Thank you. You know, I have had the opportunity as of this airing, it'll be a few days ago, to attend the 50th anniversary of the Association of Black Cardiologists, where my husband is on the board. And so I recognize the importance and value that those types of organizations where people of color can define issues and come together and lead. And it was amazing to see the energy around their cardio justice initiative. And so on the other hand, we have your organization, the Association of Black Gastroenterologists and Hepatologists, which is very new. So tell us why you started the organization with your illustrious colleagues, whom I love, and why in this moment.
You know, we were founded as the Association of Black Gastroenterologists and Hepatologists in Black History Month. We had our first event, Black History Month of 2021. And for us, it's similar to the Association of Black Cardiologists. It's one of those for us, by us moments. And I think about, what's core to our mission is advancing equity in Black communities. It's promoting and advancing science and promoting the careers of Black gastroenterologists, hepatologists, and scientists. And it's so critical that we do this because we see it's personal, number one, to many of us in our families, those of us who are co-founders of this association, who, whether it's been a personal encounter, whether it's been one of our family members, loved ones, friends, how disparities that you might read about in a statistic, you might see in a journal, you might see in an article or highlighted on a newsreel, that's very real to us. It's a lived experience. But it's also an opportunity to change the landscape. And we saw an opportunity to be a part of that solution in the landscape. And it's a gap. Donna, and many others do, that, if you wanted to find a Black gastroenterologist or hepatologist, you might have to know someone who knows someone who's plugged in to find one, because there's such a disparity in Black gastroenterologists and hepatologists. I mean, when we look at the face of America, the face of gastroenterology, the face of hepatology does not look like the face of America as far as diversity. And so we want to help change that. We want to be a resource for patients, for advocates, for the community, for our peers. But we also want to drive some actionable, some meaningful impacts.
We've been waiting for you. I'm going to say that as a patient with both IBD and liver disease, and as head of an advocacy organization, I'm going to say welcome. We've been waiting for you. We have a long list of things that we want your partnership on, but a little more seriously, I remember when I started in transplant advocacy professionally, that I knew every single Black transplant surgeon. Um, I didn't need both hands to count them, and it's taken a long
Mhm.
time to change. And I recognize, um, to be a hepatologist in particular, you have to go through internal medicine, gastroenterology, and then a transplant fellowship. And so there are so many other paths that really smart kids, smart young people could take. And some far more lucrative, before they become a board certified hepatologist. And so, how can we encourage people? I co-opt every med student. Anytime I'm in the hospital, I'm like, look at what hepatology can do. Look how fun gastroenterology. But I'm sure you have a better way of attracting young people and young med students into these careers.
Well, I think on the one hand, I think it's important that we are visible,
Mm-hmm.
that students, community members, parents see us. And not only do they see us, hopefully they might come to see us in the clinic, but hopefully they see us in the community as well. We want to be present and have that relationship. So I think it starts there. It starts with a relationship. It starts with visibility. I think too, there needs to be a pipeline of mentorship that allows people to get the resources, the knowledge that they need to be successful in this career path. They need to see us being happy, right? Because certainly in the field of medicine, there's burnout.
Mm-hmm.
There's unfortunately, there's a fatigue that's just beyond being tired. And so we have to show that we are enjoying what we do and we are thriving to make it attractive to students. But also we have to help overcome some barriers, such as financial barriers. I mean, as you may know, Donna, the average debt that someone, including college debt, is about
Mm-hmm.
$200,000. And that's very real to some savvy college students who are coming up and thinking about their career path. They're like, I don't know about that. So we have to think about ways that even financial barriers that we're helping people to navigate and think through.
There's some medical schools I was reading that have made large investments so that medical students could graduate debt free. And I think that is definitely part of the solution if we want the um, specialists that we need. When I look at the rising cases of liver disease and different digestive diseases, I sit on the board of a hospital, so I see how many liver cancer, and transplants we do, and they're only rising. And so we need more gastroenterologists and hepatologists, for that. And the data also shows that if you have a physician who is, racially or ethnically concordant, then you're likely to get better care. We need everybody to be, culturally excellent.
Yes.
I don't want somebody who's really competent. I really want a doctor who's culturally excellent, and that needs to be every physician. But if
Mhm.
you have a doctor who is racially and ethnically concordant, um, they do tend to the care. The literature and the data does bear out that care is often better.
Yeah, there are certainly certain conditions in that the data supports where racial or ethnic concordance matters. And we're still learning more in this area. There's active research happening in this area specifically. To drive your point home that you made, it's important that every provider, healthcare provider, be culturally humble, that they, relate and want to whom they meet. This goes beyond just a 15-minute, almost transactional visit, right?
Mhm.
Our work with patients as providers has to be relational more than it is transactional. And I think that starts with having cultural humility, like you point out.
So much of medicine really is based on trust, and certainly patients who are dealing with chronic illnesses, like a lot of digestive diseases, which is a lot of patient reporting what's going on with us, that the doctor has to believe and help us navigate through. Liver issues, or some of the early symptoms in particular, are subtle. some of the digestive symptoms are embarrassing, and so I think trust is so important, particularly for patients and their physicians with digestive diseases, that um, we can't have high quality care, we can't have equitable care unless we have a foundation of trust.
Yeah, I mean, just think about, I mean, this is for the person who's listening or watching this and who may not have liver disease or
Mhm.
gastrointestinal disease. I mean, just think about going for a routine checkup to your
Mhm.
doctor. You're not going for symptoms, but even then, it's a time of vulnerability.
Right.
You're exposing yourself, right? Not only physically, but you are sharing a story, a personal story with someone. And that requires trust to be in an environment in a place like that and to feel comfortable exchanging that information or sharing your body with someone else. And I think that we as healthcare provider, as a healthcare provider community, need
Mhm.
to continue to refine how we build trusted relationships and foster them.
So, what have you found that advances or helps drive health equity and more trust in healthcare, particularly the things that ABGH is doing to advance that work?
I, I I think about a few things. Number one, we really do start with community.
Hmm.
And so one of our first events when we did last Black History Month, February of 2021, was with the community. And
Hmm.
so core to what we do is partnership. It's not prescriptive, this is what you need to do. It's how can we work together to achieve a common vision, mission and vision and outcome that we are trying to push for. And so that's one. Another piece that's critical to that and building trust is being authentic.
Hmm.
You've met our ABGH board members, probably most, if not all of them.
Wonderful.
We are who we are each and every day, on screen or off screen. But I think that also allows us to build rapport with different audiences because they know that we are going to give them the truth
Hmm.
and give them reliable information. I mean, just look back on the pandemic,
Hmm.
early in the pandemic, before vaccines, and certainly at the start of vaccine dissemination, where folks were just hunting for a reliable source of information, someone they could trust, some source of truth. You know, that's core to what we do, whether it's our work in connecting with community partners
Hmm.
to advance, for example, our first event was around colorectal cancer, for example, or it's our work to advance careers of future gastroenterologists and hepatologists.
Hmm.
Just yesterday, we had a webinar with
Hmm.
future gastroenterology residents and students to talk about the pathway to getting
Hmm.
into this career and tips and tricks to be successful.
Hmm.
Or if it's advancing the science, it's what we write, how we share best practices. And that's a place where we've been vocal as well, writing in journals to, again, speak that truth and build rapport with our audiences.
So, what was your path? I see that you put a stamp on, every well, not every, so many incredible, every really university that you would need to have is supporting you. You've built such a large core house. You have the Morehouse people and the Howard people and the Duke people and the Ohio State people, and you even have the Harvard people all behind you. That's really smart. There's nothing, no office that you would go for. There's nothing that you would ever want to do that you couldn't succeed in with that cohort of alumni groups behind you. So tell us about your path.
I'll tell you, I still can't fully explain it. Besides just saying, it's the grace of God, and I mean that truly. I'm telling you authentically.
Mm-hmm.
I would say this off screen, and folks that know me know
Mm-hmm.
I'd say the same thing. But it's not, for me, it's nothing but the grace of God. I tell you, the spark initially for a career in medicine started with my dad. So I'm the second, Daryl Mason Gray the second.
I love hearing that. Any that has seconds and thirds and fourths is something to be celebrated. So yes,
Yeah.
please.
Thanks. Yeah, it started with my dad, and he practiced internal medicine in inner city Baltimore
Mhm.
and really built a relationship first, continues to foster relationships even outside of now being gone from practicing medicine. But he saw people for who they were holistically, and did so whether they were able to compensate or not, whether they were wealthy or whether they were impoverished. Relationships with them just the same. And I saw the impact that had on times, in times of wellness and in times of illness. And I wanted to model that. And so for me, kind of coming through the ranks, ultimately going to Morehouse, getting exposed to their biology program, loving the sciences and really feeling a pull towards medicine, pursued another HBCU in Howard, which I felt for me was the environment in which I could learn best, in which I could succeed best. That really then laid the groundwork and the platform for me to really go to other institutions across the nation. You mentioned Duke, where I did my residency, but that also opened up my eyes to global health, because I spent some time in Kenya, about 3 months during my senior year of my residency, and doing work in WashU at St. Louis, and so on. And the list goes on, but it's been kind of pivots that don't always kind of fit into the natural mold of the career path of a gastroenterologist that I felt that I've just been kind of led to. An example of that is, following my gastroenterology fellowship, a natural progression would have been either to go into private practice or to go into an academic faculty position. Well, what I ultimately was led to do and pivoted towards was doing a health policy fellowship. So I participated in the Commonwealth Fund Fellowship in Minority Health Policy at Harvard. And then after that, went into kind of academia. And now I'm in industry. And so these, if you would have asked me, 10 years ago, even 5 years ago, maybe even 1 year ago, would I be taking these moves that I've taken over time? I would have said no. But these opportunities at critical time points, and with a common vision through all of them, that it's about advancing equity. It's about improving the health of not only one patient that I encounter, for someone I get to see on an individual basis, but communities and hopefully our nation as well.
I think that's so powerful. I also have a career that only makes sense in retrospect. But like you, I know someone else has the plan, so I don't. I just need to, follow.
Yeah.
I chair a group for Academy Health on high value equitable care. But it's not very easy, and it's not consistent across systems and literature to date about what equity looks like or what equity means. So perhaps generally, and then more specifically in gastroenterology and hepatology, what would equity look like?
Yeah. I veer more towards the Robert Wood Johnson Foundation definition of health equity. And that means when everyone has a fair and just opportunity to be as healthy as possible. And within that, as I think about equity, and I think about it in the context of gastroenterology and hepatology, I think it requires that we certainly take a holistic approach, but that we elevate or prioritize some of the work and the resources around historically marginalized populations. And so, this and people in some cases will say, "Oh, you're making this a race thing." No, it's not. People certainly of a particular race, focus of equity is always on. But there are other dynamics, whether it be income, whether it be geography, such as rural versus urban, whether it's those who have limited English proficiency, whether it's age-related inequities. We need to prioritize those who are facing the inequities. And in part, that can be around quality, the quality of care that people receive. To go to your point, the value, that hopefully they're getting high value care, and how can we close the gap on those who are not? I think too, how do we build, and that's kind of patient facing, right? Or community member facing.
Right.
but how do we enable the providers to deliver on equity? And
Right.
maybe that's with value-based
Mhm.
contracting. Maybe that's education around racism and implicit
Mhm.
bias and how they can be more culturally humble in the patient encounter. Um, I think it has to be all encompassing. And as we think about equity,
Mhm.
again, I think try to think about it holistically. So it's not just those things that happen in the clinic or in the hospital or in your virtual visit, but it's social health. What are
Right.
we doing to address those upstream determinants
Mhm.
or drivers, such as food insecurity or housing instability, that can lead to those poor outcomes? Or what are we doing in the behavioral health space, as that is very much linked to physical health? I mean, it
Right.
has to be a whole health approach to equity as well.
Absolutely, because those are whole people presenting. Um,
Hmm.
as I have talked to my various ologists, or even just on a gastroenterology board, I'm like, I have both a liver and and a colon and a small intestine and all the parts. I have all the parts and all the things, and so we're
Hmm.
gonna
That's right.
that all the things, because um, any recommendation or any path that we go down for intervention is going to affect all of that, and certainly as a patient with digestive diseases, considering the mental health. There's so much depression that comes in. Same with many liver diseases as well, and so really thinking through whole person health. We, from a policy standpoint, we've been involved in the medical health equity nutrition, medical nutrition and health equity act, to make sure that people have access to the type of foods, particularly if they're medical foods, that they need for their digestive health. There's no point calling somebody non-compliant, in the
Right.
medical records, when they simply can't afford the specialized food, or they can't afford the gas to go to the physical therapist or the behavioral health specialist.
That's right.
And so, I really think that we need to know our patients, and be flexible enough um, to, individualize and personalize care. And I think what we're struggling with in many health systems is, how do you do equity at scale? Isn't it something that has to be so bespoke that, we can't possibly do it across, populations of people? And I think that it's personally, it's a fun challenge to demonstrate how it can be done at scale, with attention. I think aligning, patient-centered care and personalized medicine, and rolling that up into equitable care for individuals, is something that we can do if we put our minds to it.
Oh, absolutely. And you're preaching. You are preaching to throw in here. So yes, absolutely.
Well, I think that's what's exciting about what you and ABGH are doing. That being at centers all across the country, and having connections, as you said, in Kenya and all over the world, you can uh, share best practices. You can solve a problem at one institution and say, hey, maybe this can work across others. And so maybe it won't be sort of siloed or individual posters, or an article, or a pilot. um oh my goodness, I love pilots. We have more pilots than Delta Airlines. But can we put them all together and say, this is now how healthcare is going to be done, and delivered, because we've shown it works. And so the opportunity to share and accelerate those best practices, I think, is exciting.
Yeah, and build, continue to build a network that hopefully will just grow and grow and grow of Black gastroenterologists and
Mhm.
hepatologists, and be a trusted resource in the community, and also be a bridge and hopefully an inspiration to other groups that are forming. And certainly we have had the blessed experience of having groups reach out to us. Hey, we want to kind of replicate what you're doing, but in this community.
Mhm.
And so I think that's also refreshing to see. And that's hopefully the result that we'll continue to see.
It is truly inspiring. It's also wonderful to have a place, a hub, people have ideas, whether they're, research ideas or program ideas that they want to get off the ground, but they don't quite know who to send it to. GLI serves as that place within liver community, sort of writ large, and I spend a lot of time sort of mentoring and matching, people and ideas and practices. And so I'm sure there are a host of issues that people are so relieved that they can now lay at your doorstep. You're like, here, but there are real issues from, some of which, and I've gotten where there are folks who want to invest, who want to do research in equity, that don't have enough funding to do it full time, or they come up against review committees that sort of disregard the premise of what they're doing, that disparities don't exist in transplantation or other areas. And so how will sort of creating this network and this sort of united front and community now help to have people have a home for research and make it easier for people to do this research, to do this work moving forward?
Yeah, I think one of the strengths of ABGH is certainly our people. We came together with co-founders who are thought leaders, across the nation, and leading investigators in research studies, whose practice is also built around community engagement, and who are just stellar clinicians. And so in their own right, they've been thought leaders. And so collectively as a group, what's happened is we have partnerships with, pharma, for example, who wants to better understand from a thought leadership standpoint how they should build programs that are culturally humble, but how they can also, what opportunities there are to fund research that impact Black communities. And so we are able to leverage that and be that resource. And we're also able to simultaneously help to cultivate trainees who are coming up in the ranks, to give them opportunities to participate in some of the research studies and some of the journal article writing. So that, and also these are some of the trainees who may end up going into fields as scientists or join industry ultimately. So we're exposing them to different careers and building such a rich network of experience, but also a network of relationship in trying to advance equity.
I think that's so important for this to be more than just a moment. It needs to be the way that healthcare is done moving forward. And so I'm so very excited that we have the enduring resource that is the Association of Black Gastroenterologists and Hepatologists, and the leadership that you've already brought to so many of the medical societies in the digestive space. I would be remiss if I didn't say that you've already been winning awards and creating centers that you have had certainly an effect in the community, but you've also had quite an effect within the establishment of medicine and digestive medical societies that is I think will create the infrastructure for making sure that this is a sustainable movement and not just a moment.
Yeah, absolutely. I think, one of the things, and I so appreciate that you said that, because one of the things that we want to do, we don't want to work in a silo. That's not how we need to operate nowadays. We shouldn't have operated that generally in the field of medicine and academia previously. We want to collaborate with other societies. And certainly we are thankful to the support from many societies who have collaborated, elevated, promoted us thus far. And that's how it should be. Collaboration.
It's fantastic. We will absolutely make sure that the website and your fantastic Instagram handle is in the show notes as this goes out. But any last takeaway for us before I reluctantly close off this conversation?
No, Donna, I am thrilled that you thought enough of us to allow us to represent on your show. And we honestly are excited about future opportunities. Thank you for being a partner, number one. But we're excited about what that means in the future. And let's continue to just keep pushing so that we can advance towards health equity.
Absolutely. Thank you. Let's do that.
Thank you.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.